Good morning, sir. Sir, myself, Dr. Neeraj from AIIMS Rishikesh. I'll be presenting this case, sir. My patient is a 47-year-old lady. She is homemaker, a resident of Rishikesh, Uttar Pradesh, Uttarakhand. She has chief complaints of increased frequency of stool mixed with blood on and off since 2019, and it was associated with abdominal pain on and off since 2019, sir.
So as soon as you hear these presenting complaints, what comes to your mind?
Sir, with these complaints, patient can be having inflammatory bowel disease, sir.
Yeah, so
Most likely, yes, sir.
at a very early stage, I would probably not jump straight to the diagnosis. I would say that probably she has a colorectal pathology, probably left colon or rectum, because it is, uh, although it's not mentioned the fresh blood, but looks like fresh blood, it is not melena.
Yes.
Also, because the duration of symptoms is long, it virtually rules out malignant pathology. It looks more like a benign pathology. So, benign could be infective or inflammatory. Now, infective, the commonest colorectal pathology giving rise to increased frequency of stool mixed with blood is what?
Sir, can be CMV colitis or C. diff colitis, sir.
Yeah, so in our setup, an acute episode is amoebic colitis.
Sir, in acute episode is amoebic colitis, but with this much prolonged history, sir.
Yeah, so with such a long history, although recurrent amoebic colitis is a known entity, incompletely treated or inadequately treated, but such a long history is very, very unlikely. So then you say that most likely it is inflammatory bowel disease. Okay.
Okay, sir. Sir, patient was apparently well till October 2019 when she developed increase in stool frequency from 1 to 2 episodes per day to 5 to 6 episodes per day, which was small in quantity, liquid to semi-solid in consistency, and it was mixed with blood and mucoid content. This increased frequency of stool was associated with the acute onset, mild to moderate intensity, lower abdominal pain, which was spasmodic in nature and usually relieved after the passage of stool. There was no associated history of fever during that episode, sir. She was evaluated for this condition at private hospital, and lower GI scopy was done, and she was started on oral medication twice a day, following which she had a relief in symptoms with stool frequency reduced to 2 to 3 per day without any episode of bleeding. She continued her medication for 4 months, and then she stopped by herself. Then she again developed similar symptoms with stool frequency of 10 to 15 times a day, and all of the stools were mixed with blood and mucoid content. She was then hospitalized and started on IV medications. Her symptoms improved after shifting to oral medication. Her symptoms improved, and after that, she was shifted to oral medication. One of those medications was tapered over 3 months. Other oral medications were continued twice a day, along with the rectal formulations were given. Since then, she has had 5 such episodes with 3 times hospital admissions. She was on oral plus rectal medications. Oral medications were changed in between, and rectal formulation was given twice a day. There is history of blood transfusion during 2 admissions. Last episode before this admission was in August 2023 when she was hospitalized and again started on oral IV medications. Following which symptoms improved after day 3 or day 3 to day 5, and she was shifted to oral medication. Again, one of the medication was stopped, and other medications continued with rectal formulations. Current episode started in last week of January 2023, around 2 weeks duration, with 10 to 15 episodes of liquid bloody stool with moderate to severe intensity crampy abdominal pain. There was no radiation or referral of the pain. Pain aggravated on food intake, and patient developed food fear. Patient has history of urgency and nocturnal defecation at present, and she also complained of low-grade fever spikes. There is history of loss of appetite and loss of weight is present. She has lost around 10 kg over 4.5 years. So she regained weight in between, but she lost again. Uh, she also complained of generalized weakness and fatigue. There is no history of blood transfusion in this current admission, sir. There is no history of colicky, abdominal pain and distension, or vomiting or ball rolling sensation or hematemesis or melena. There is no history of perianal pain. There is no history of perianal pain, discharge, mass coming out per rectum or incontinence. There is no history of sense of incomplete evacuation, tenesmus or spurious diarrhea. No history of urinary complaints in the form of burning, micturition, pyuria, pneumaturia, or fecaluria. There is no history of joint pain or bony pain, back pain or neck pain. No pruritus or jaundice. No history of skin nodules, ulcer, or skin lesions. There is no history of redness of eyes, watery eyes, or visual disturbances. There is no history of chronic cough with expectoration or recurrent fever episodes or sore throat. In past history, there is no known comorbidity and no known allergy. She has not underwent any surgery in the past. She do not have any similar illness in the family, and she is vegetarian by diet. Appetite is reduced as of now, and bowel habits are disturbed. Sleep is disturbed with nocturnal defecation and crampy abdominal pain. Her bladder habits are normal. She has no addiction. She is not a smoker. She is a premenopausal lady with the para 3 live 3 status. Her last menstrual period was 25th of January 2024, and lasted for 2 to 3 days. Her usual cycle is 30 days. In treatment history, there is no history of prolonged medication intake other than medication for this illness. Sir, shall I summarize, sir?
Yes, yes.
To summarize, 47-year-old premenopausal lady, para 3 live 3 status, without any comorbidities, without any addictions, with no history of previous surgery, presented with the history of frequent passage of bloody stools, with crampy abdominal pain on and off since 4.5 years, with multiple hospital admissions, with blood transfusion twice in admissions, receiving treatment in the form of IV and followed by oral medication and rectal formulations. Now presented with similar illness since 2 weeks with low-grade fever spikes. She has lost around 10 kg in the past 4.5 years. So based on the history part, my provisional diagnosis is inflammatory bowel disease, most probably ulcerative colitis with relapsing remitting course, sir.
Anything else you would like to add for the current episode or the previous episodes? What are they likely to be?
Likely, sir, these are acute severe episodes of ulcerative colitis, sir.
Because ASUC is a known described entity, acute severe ulcerative colitis. Although we can say that definitely after examination and some preliminary investigations, but it looks like because
Looks like
she has, you said about 10 stools per day, there is blood, she has
blood.
fever. So
Yes.
most probably these episodes are what is known as acute severe ulcerative colitis. Okay.
Yes.
You said no history of ball rolling movements. Why? What did you want to convey?
Sir, if the patient is having on and off intermittent, on and off abdominal distension with ball rolling sensation, then she may be having involvement of small bowel as well, suggesting features of subacute intestinal obstruction, which may favor towards Crohn's disease rather than ulcerative colitis, sir.
Yeah, so ulcerative colitis is a disease confined to the large bowel only.
Yes,
If
sir.
there is any suspicion of involvement of the small bowel, then your diagnosis tilts more towards Crohn's disease. You start thinking of tuberculosis in
Yes,
our
sir.
patients, but ulcerative colitis that does not involve any part of the GI tract other than the large bowel. Uh, you said she has lost significant weight. What do you interpret from that?
Sir, she has had multiple episodes of acute flare-ups, sir, and she is having food fear as well, because she is having crampy abdominal pain, which relieves after defecation, sir. So this is attributed because of poor nutritional intake as well as chronic inflammatory state, sir.
Anything else you would like to think about?
Sir, though history is prolonged, though not as prolonged, but patient can be having malignancy over ulcerative colitis, sir.
So in this case, in your diagnosis, you haven't suspected malignancy. When would you suspect malignancy in a patient with ulcerative colitis based on history?
If the patient develops sir, abdominal distension or features of bowel obstruction, uh, then I would suspect malignancy in UC, sir. Probably stricture is developing over the picture of ulcerative colitis, sir. Then I'll suspect malignancy, sir.
Nothing else. That's all.
Sir, patient is having a weight loss as well, sir, and
Does the age
her age is towards 50s, sir. Another thing would be,
does the age of onset or duration of
yes, sir.
illness?
Duration of symptoms are 4.5 years, sir. Usually, malignancy is seen after a mean period of 8 years, sir, in ulcerative colitis, sir.
So younger age at onset, longer duration of symptoms,
Yes,
uh, significant weight loss, features to suggest obstruction, or suppose the patient herself has palpated a mass. So these are some points in the history. We will then go on to examination and investigations. So extent of involvement, if it is pancolitis, that
yes,
also is a
pancolitis.
factor. Okay. So any patient who has long duration of history and who has lost a significant amount of weight, you have to keep that possibility in mind. Here, another point which is not in favor of malignancy, that she lost weight and then she regained it,
Then
which
regain
means
it
that it is
because
not
of flare-ups, sir.
loss of cachexia of malignancy, but it is weight loss of poor intake or poor nutrition. Okay. So between the two, ulcerative colitis and Crohn's disease, you have mentioned ulcerative colitis is your first diagnosis. Why do you say so?
Sir, patient's predominant feature is bloody diarrhea, sir, which is more favoring towards ulcerative colitis. Crohn's disease patients usually will present more with the abdominal pain, with colicky abdominal pain with distension, with involvement of small bowel, sir.
Sir, may I interrupt?
Yes, Rajen.
Yeah. Just based on bloody stools and pain abdomen, can you rule out polyps? I'm not talking about treatment history. Exclude the treatment history just based on the patient's history. Can you rule out polyp disease with recurrent intersusception?
No, sir. I won't be able to rule out the polyp disorder, but she has not given any history in the family, sir. So that is not favoring towards polyposis coli, sir.
But it can be sporadic
Yes, sir. It
polyps.
can be correct. Yes, sir.
A villous adenoma would present like this.
Yes, sir.
Yeah, but I probably would slightly disagree in the sense that polyps can cause diarrhea, but that is usually mucus diarrhea only because of excessive secretion of the mucus. And this episodes of remission and relapses uh, probably is more typical of inflammatory bowel disease. And uh, so polyp, the classical presentation is just bleeding per rectum. Associated
Correct.
with that, there may be excessive mucus discharge, but 10 stools per day would be a little unusual with polyp. Although in every patient with bleeding per rectum, fresh blood per rectum, especially in children and adolescents and young adults, you have to keep the possibility of polyp in the background. And absence of family history doesn't rule it out. See,
Yes.
all these points, absence of contact, absence of family history, they do not rule out a diagnosis. If it is there, it helps you to make a diagnosis. But if they are not there, same as many students say that since there is no anorexia and weight loss, it is not malignancy. No, that is not correct. If it is there, it supports a diagnosis of malignancy. But if it is not there, it doesn't mean that it cannot be malignancy. And
Yes.
you should also say that ulcerative colitis is more common than Crohn's disease, even in our patients. So between the two, ulcerative colitis, and as you said, that there is no small bowel involvement, there is no perianal involvement. These are all features which distinguish ulcerative colitis. And
Sir, shall I proceed with the examination, sir?
yes, please.
Sir, on examination, she is thin built. She is alert, conscious, cooperative, and oriented to time, place, and person with WHO performance status of 1. Her BMI is 19.15 kilogram per meter square with height of 155 centimeter and weight of 46 kg. She is having pallor. There is no icterus, cyanosis, clubbing, lymphadenopathy or edema. She is well hydrated. On vital examination, she is having pulse rate of 94 per minute with the blood pressure of 128 by 76 mmHg in left arm supine position. Respiratory rate is 18 per minute and temperature of 98.6 degree Fahrenheit. Her breath holding time is 30 seconds.
नॉर्मली बीपी कौन से आर्म में मेजर करते हैं?
Sir, right arm, sir.
एनी स्पेसिफिक रीजन?
No, sir.
कौन सा कंडीशन सस्पेक्ट करते हैं जब राइट और लेफ्ट दोनों में मेजर करते हैं?
Sir, if we are suspecting coarctation of aorta, then there may be difference of more than 10 in systolic pressure, 10 mmHg of systolic pressure, sir. In coarctation.
कौन सी कंडीशन है जब चारों लिम्स में मेजर करते हैं?
Sir, if we are suspecting stenosis of descending thoracic aorta, descending aorta, sir, then we will measure in all four limbs, sir. There will be difference of more than 20 in lower limb systolic blood pressure, sir, and difference of more than 10 mmHg in upper limb, sir.
I think peripheral vascular disease.
Yes, sir. Sorry, sir. Peripheral vascular disease. On oral cavity examination, hygiene is good with adequate mouth opening, no mucosal lesions seen.
Why mouth opening?
Sir,
Specifically mention mouth opening.
Yes, sir. That was not per se with respect to the disease process, but if we are contemplating surgical intervention, then it is important, sir.
Yeah, so it's more from.
Yes, sir.
So it has nothing to do with our. Yes.
Sir, on abdominal examination, on inspection, abdomen is flat. There is no.
You don't have to go through. Don't go through all the what is written. Anything significant?
There is no significant finding on abdominal inspection and palpation, sir.
But what were you looking for?
Sir, any visible peristalsis, if any distension is present and along with that any visible peristalsis is present, then it would suggest towards obstructive features, sir. And any lump, if it is palpable, then it may suggest can be because of Crohn's disease or because of any mass lesion in the setting of ulcerative colitis, sir, favoring towards malignant etiology, sir.
In a patient with the suspected diagnosis of inflammatory bowel disease, if you palpate a lump, what does it indicate?
Sir, in case we are suspecting ulcerative colitis more than Crohn's, then it would suggest most probably malignant etiology. And if we are suspecting Crohn's more than ulcerative colitis, then it would give us clue of sir, fistulization process ongoing or any mass lesion, inflammatory mass lesion, sir.
In Crohn's disease, what is the commonest cause or what is the commonest situation that you palpate a lump in the abdomen? What is happening?
Sir, at times patient develops intra-abdominal abscess or phlegmon, sir. So because of that, we may find a lump in Crohn's disease, sir.
Yeah, or so in Crohn's, usually the lump is ill-defined, tender lump, which is, as you rightly said, a phlegmon, which means there may be a small perforation, there may be a fistulation between adjacent bowel, and so that is more common. Whereas in ulcerative colitis, because it is the basic difference is the ulcerative colitis is a mucosal disease, whereas Crohn's is a transmural disease. So in ulcerative colitis, perforation is known. Perforation and localized collection or abscess formation is known, but it is more common with Crohn's than with ulcerative
Ulcerative
colitis.
colitis.
Anything on here?
Sir, on percussion and auscultation, there was no positive finding. On distal rectal examination, perianal skin was normal. There was no fissure, fistula, or skin tag or external hemorrhoids or perianal excoriation. Anal tone was normal with good squeeze pressure. There was no growth palpable, and finger was stained with mucoid content, which was mixed with blood. And on proctoscopy, erythematous rectal mucosa was seen. There were no internal hemorrhoids or growth palpable, growth seen, sir.
Yeah. So in all patients with ulcerative colitis, a good per rectal examination is very, very important. Why?
Sir, we need to look at the perianal area to look for its involvement in the form of fissure, perianal fistula, or perianal excoriation. Sir, fissure, fistula, or perianal abscess would suggest more towards Crohn's disease, sir. And perianal excoriation and continence or anal tone we need to look at, sir, because if we are considering surgical intervention, then will we be able to will the patient be able to maintain continence or not?
Yeah.
Perianal
So
excoriation can be because of that only. Patient may be having incontinence, and the patient is using diaper, and patient is having perianal excoriation, sir.
Why in this
if you are,
patient?
Sorry, sir.
Why in this patient? Anything in the history that uh, prompted you to check anal tone?
Sir, patient is having urgency, but there is no urgent incontinence in the history, sir.
There is night incontinence.
Night defecation, nocturnal frequency, nocturnal defecation history is there, but there is no night incontinence, sir.
Okay, I thought it was night incontinence. Sorry.
I also thought you said nocturnal soiling.
No, sir, nocturnal defecation, I told you, sir.
So if there is any history of incontinence, whether with increased frequency of motion, whether it is for liquid stool, whether it is for flatus, whether it is nocturnal, and even otherwise, a good, detailed, proper, uh, directed perennial examination is very, very important. Before you contemplate any ileal pouch anastomosis or a restorative proctocolectomy surgery, you have to make sure that the patient has good tone and good squeeze. If there is
Yes.
any doubt, you may have to do further investigations, which we'll discuss, because if you perform an IPAA or RPC in a patient who has a poor sphincter, then the quality of life is going to be very poor, because even otherwise patients may have some minor incontinence, and if the sphincter is not adequate, tone is not adequate, the patient may suffer from incontinence and will be greatly troubled by it. So it's very important also when you start managing these patients that you yourself must do a good digital rectal examination. So elderly patients, those who have a poor sphincters like multiparous women, you may have to rethink whether you would like to do a ileal pouch anastomosis or not.
How is fistula and continence related?
Sir, the patient may be having perianal fistula that is involving the sphincter, sir. So while managing as well, managing the fistula or even perianal abscess, we need to take care not to injure the anal sphincter, sir.
In inflammatory bowel disease, what kind of fistula treatment will you use?
Sir, will give sir anti-TNF alpha therapy after ruling out infective etiology, sir. Uh, we won't go for operative intervention straight. If there is perianal abscess, then I would go for
Not
drainage of.
infective pathology, but there should not be gross infective symptoms
Yes, sir.
in the form of raised CRP or a raised WBC count. Why is that important in infliximab?
Sir, because there may be a flare up of pre-existing infective process ongoing, sir. So that will flare up, sir, and that will land up the patient in frank sepsis, sir.
Okay.
Yeah. Presence of any sepsis, and also in our patients, you have to keep tuberculosis in mind, may become a relative
Active tuberculosis.
contraindication for use of any of the biologicals. So what will you do?
Sir, based on the current history and examination, I will admit the patient and start resuscitating with IV fluids and correct the electrolyte abnormality if any present. And simultaneously, I will check for the previous records and treatment records of the patient, sir. Sir, this is sigmoidoscopy, which was done in 2019, which shows normal anal canal. Rectum in rectum there is loss of vascular pattern with erosions with mucosal bleed. Rectosigmoid and sigmoid colon was normal. Biopsy was taken from rectum as well as sigmoid. In impression, it is given as inflammatory bowel colitis with ulcerative colitis, Mayo grade 2 colitis with US EIS of 211 and E1 disease cell.
When would you
What is
not
this?
do a sigmoidoscopy or a colonoscopy in a patient with UC, suspected UC?
Sir, if the patient is having abdominal distension and features are suggestive of toxic megacolon, then I won't go for sigmoidoscopy or colonoscopy, sir.
What is the investigation for diagnosis of ulcerative colitis?
Sir, sigmoidoscopy with biopsy is the investigation for diagnosis of ulcerative colitis, sir.
Actually, it could just be a proctoscopy and biopsy, because in more than 90-95% of cases, the rectum will be involved. So colonoscopy is not the investigation for diagnosis. Colonoscopy is the investigation for
to check for the extent of the disease, sir. And yes, sir.
yes. For diagnosis, you just have to look at the rectum, which can be done with a proctoscope or a sigmoidoscope.
Sigmoidoscope.
And then once you establish the, suppose rectum appears normal, that is known, rectum sparing, but then that will be small number of cases. So if your clinical
It's less than
suspicion is
5%
strong,
cases.
yeah, but rectum is not involved, then obviously you will do further investigation. So many students make this mistake. As soon as they suspect ulcerative colitis, they say colonoscopy. That is not correct. And also, as Dr. Desai was trying to ask you, there are certain situations where colonoscopy is contraindicated. So if you, especially if you have a toxic megacolon, even during an episode of acute severe ulcerative colitis, you just do a proctoscopy and establish the diagnosis and treat, and then you can do the colonoscopy later.
Later on, sir.
What is UCEIS?
Sir, ulcerative colitis, extent of severity score, sir. It has got three parameters, sir. Vascular pattern we see, sir, and we look for bleeding, and we look for mucosal erosion or ulcer, sir. So each is graded according to the vascular, like in vascular pattern. Sorry, sir.
I don't know. Check with your medical colleagues what exactly are these parameters. I'm not sure. Okay.
Okay, sir. On histopathology, sir, rectal biopsy showing severe chronic active colitis consistent with ulcerative colitis, and sigmoid shows features of normal. Sigmoid biopsy was within normal limits.
So based on this report, what would you say is the diagnosis?
Sir, based on this report, this case is having inflammatory bowel disease, ulcerative colitis, with even disease, and a CVT score of 3, sir, S3.
Sigmoid normal on biopsy.
Yes, sir, sigmoid is normal biopsy.
So what does it mean?
Sir, patient is having proctitis only, sir.
Ulcerative proctitis.
Ulcerative proctitis.
Because ulcerative colitis usually has continuous involvement. Patchy involvement or involvement, then normal, then involvement again is very unusual. So if sigmoid is normal, most probably, although we haven't done a full colonoscopy as yet, but most probably it is ulcerative proctitis.
Sir, colonoscopy was done in 2020, sir, which showed anal canal was normal and rectum and rectosigmoid was involved, sir, with complete loss of vascular pattern with erosions without ulcers, sir. Rest of the colon was normal till proximal 10 centimeter of the ileum, and biopsy was taken from all the segments of the rectum and colon, sir.
So this again confirms that the disease is confined to the rectum and sigmoid.
Rectum and sigmoid, sir.
Or even not even sigmoid, just rectosigmoid.
Sigmoid, sir. Biopsy was again suggestive of moderate chronic active proctocolitis. There was no granuloma or viral cytopathic changes, dysplasia or malignancy, and the CMV, IHC were normal, sir, negative, sir. Sir, upper
Why
GI.
was upper GI why was upper GI endoscopy done? Would you do?
Sir, upper GI endoscopy was done to look for to again rule out Crohn's disease only, sir, because Crohn's disease can involve anywhere in the alimentary tract, sir. So upper GI endoscopy was done for that purpose only, sir.
Here, everything is pointing towards ulcerative colitis. In the histopathology, there is nothing to suggest Crohn's disease. So you would do an upper GI endoscopy or a small bowel evaluation only if you have a suspicion or if you can't differentiate between ulcerative colitis and Crohn's
Sir,
disease.
if we are not able to differentiate, then I would definitely go for upper GI endoscopy. But if we are having straight away scopy findings and history wise, we are suspecting more of ulcerative colitis, then we can defer, sir.
What is the pathognomonic sign of ulcerative colitis on biopsy? Is that there in this case?
Sir, patient will have a crypt distortion, crypt architectural distortion, and crypt abscesses. Though it is found in Crohn's colitis as well, but cryptitis is a pathognomic of ulcerative colitis, sir.
So is it there in this case? At least in the biopsy report that you showed us, it's not there. They only
The
written
details,
to proctocolitis.
Yes, sir.
they haven't mentioned the details, although in the first one, they have said consistent with ulcerative colitis, which means they might have seen crypt abscess is the classical. Here they have just said moderate chronic. Why do you think that there is a slight difference between this 2019 and this biopsy report?
Sir, that sigmoidoscopic biopsy was taken during the flare-up episode, sir. And this 2020 scopy was done for complete assessment and to look for extent of the disease, sir. And at that time, her colitis was controlled, sir.
Yeah, and she has received some treatment also.
She has received treatment as well, sir.
If it was only proctitis, why do you think she was put on oral medication?
Sir, she was having symptoms with which were suggestive of severe ulcerative colitis, sir. She was having around 10 to 15 bloody stools, sir. She was having tachycardia, and her ESR at that time, ESR CRP was raised, sir.
But whatever investigations you have shown in the form of scopy shows that it's a left-sided colitis.
The left-sided colitis, yes, sir.
Yeah, what is left-sided colitis?
Not even left-sided, just proctitis.
So this is just proctitis which sigmoidoscopy and colonoscopy is this thing, sir. Left-sided colitis is distal to the splenic flexure, like disease extent distal to the splenic flexure. Then it is left-sided colitis.
Yeah. So because the rectosigmoid and sigmoid is showing complete loss of vascular pattern with few erosions, so we can see the possibility of left-sided colitis. But how often is left-sided colitis going to present as severe acute colitis?
Sir, not usual. Usually, pancolitis present with severe colitis. These are the blood investigations which were done initially and in 2023 and in current admission, sir. In 2019, her blood workup was showing anemia in the form of hemoglobin of 8.1. With the raised ALP of 141 because our reference range is 120, and raised ESR and CRP 23 and 28, sir, in 2019. And in 2023, she had hemoglobin of 6.8 when blood transfusion was also given. Now her ALP was normal, and ESR CRP was quite high, sir. It was 33 and 40, sir. During this current episode, her hemoglobin is 7.1, and ALP again is 120, and ESR is 27, and CRP is also elevated. 32.6. C is also having hypoalbuminemia in the form albumin levels of 3.1, sir. The rest of the parameters were normal, sir. Other investigations during this episode were also done. Procel was normal, and her lipid profile was normal, though HDL was on the lower side, sir. HDL was below normal, sir. On stool routine microscopy, there was no ovocyst, larva, trophozoites, or segments of any parasite. C. diff toxin was negative, and CMV IHC was again negative, sir. Chest X-ray was done. This chest X-ray is showing chest as well as chest X-ray PU view as well as upper abdomen with both domes of diaphragm. In this X-ray, trachea is centrally placed. No bony abnormality is visualized, and bilateral lung fields looking normal. There is bronchopulmonary. This is abdominal X-ray with lower chest, sir, with both domes of diaphragm. Lung fields are looking hyperlucent, sir, and there are no air fluid levels or no dilated bowel loops seen. There is no free gas under both under right dome of diaphragm, sir.
But what do you see in the colon, right and left?
Sir, left colon, there is gaseous content, sir, but in right colon, looking like fecal content is there in the right colon, sir, but left colon looks empty, sir, with gaseous content, sir.
What is this? What is this? What is this? It's all fecal matter.
Fecal matter, sir. Yes, sir.
Patient with ulcerative colitis, you don't expect solid fecal matter
Fecal matter, yes.
to be there. So this again shows that involvement is only
Proctitis.
very confined to rectum and rectosigmoid. Otherwise, if it was extensive colitis, you don't expect solid fecal matter. Okay, normal
Yes.
fecal matter. So this again shows. Any other investigation you want to do?
Sir, as of now, I would proceed with this investigation, sir.
When would you do CT scan in a patient with ulcerative colitis?
If the patient is having symptoms of obstruction, sir, that will suggest the development of malignancy, sir, then I will do CT. And also in case if I'm suspecting toxic megacolon, so initially we will do abdominal X-ray to look for diameter of the colon, distended colon.
Yeah, so if there is obstruction, you suspect malignancy, then you probably first do a colonoscopy and take a biopsy. So CT will be more for evaluation of the malignancy, which
Malignancy.
colorectal you would do. If it is in the rectum, you might in fact prefer to do an MR, as we would do in a lower, middle or lower rectum. And other is if you suspect a local complication. So as we discussed, localized perforation is uncommon, but if you suspect it on clinical ground, that would be the other indication where you are trying to look for a collection which needs to be drained. So otherwise, a CT scan is not a part of the investigative armamentarium. So now what is your final diagnosis in this case?
Sir, my final diagnosis is sir, inflammatory bowel disease, ulcerative proctocolitis, sir.
So inflammatory bowel disease, ulcerative colitis, and ulcerative proctitis. Because no investigation so far at least has shown disease beyond the rectosigmoid, isn't it? So it is confined to the rectum. So it could be proctitis, it is left-sided colitis, then it is what is the third one? Pancolitis. नहीं, उसके बीच में एक और है. 4 है ना extent, Rajen? Can you?
Sir, in pediatric age group, it is 4, sir. In pediatric age group, it is up to splenic flexure and then splenic flexure to hepatic flexure and then pancolitis, sir. But in adult age group, sir, it is 3 only, up to proctitis, distal to the splenic flexure and pancolitis, sir.
Okay. So up to the rectosigmoid proctitis,
Yes, sir.
up to the splenic flexure left-sided colitis, and anything beyond splenic flexure, you say is pancolitis.
Pancolitis, sir.
So we get back to that question which Dr. Desai asked you, that if the disease was confined to rectum, why were all these systemic treatments were given? Do you agree with that, or you could have treated the patient in a different way? Because obviously she was given steroids and she was put on oral medication.
Yes, sir. Usually proctitis or even left-sided colitis won't give us that picture, sir, of severe ulcerative colitis. But her symptoms were suggestive of severe ulcerative colitis based on Tulov and Witt score, sir. So based on that, she was started on IV medication, sir.
Yeah. What about ASA drugs? Would you use only twice a day?
No, sir. ASA
Severe
drugs,
acute colitis?
sir. An acute colitis, we can give TDS or 1.2 gram QID as well. But again, the studies till now shows similar response in dose of 2.4 versus 4.8, sir. So we can go for higher doses as well, sir.
Yeah. So one reason is that whether the colonoscopy findings are not correct, but unlikely. Other is whether it was a superimposed, that she has basically ulcerative proctitis, but superimposed she had infective
Infective colitis can be there, sir.
colitis, and that was the reason. Because what Dr. Desai again and again is saying, that if it is truly ulcerative proctitis, then local treatment in the form of enemas, whatever enemas you want to give, should be good enough. Okay. So I think we are not going into the details of further management. We are already beyond time. But fortunately, this month masterclass is going to be on ulcerative colitis. Dr. Anand is trying to put the notice there. But if all of you are members of the JST, then we've already put the notice on JST. We'll put it again. And please pre-register for this masterclass. And we will have this on 2 days.
Yes, sir.
नहीं कॉपी पेस्ट कर सकते हैं उसमें जो लिंक है उसका
तो हम अपने ग्रुप पे शेयर करें जेएसटी
I hope all of you are members of JST. If not, then please send a WhatsApp message to Dr. Anand Nagar. Anand अपना आप नंबर फिर से एक बार डाल दो चैट में. So please send a WhatsApp message to Dr. Anand. He will add you to the group. And then on the group, we've already announced the masterclass. Okay.
Yes.
+91 for those who are outside India. So we will be covering all the details of medical management, indications for surgery, and how to choose what procedure, and some tips for ileal pouch and anastomosis. And also there will be discussion on we briefly mentioned about it, discussion on ulcerative colitis and cancer. When do you suspect? How do you suspect? What do you do? What is the management? So all these topics will be discussed in the masterclass in detail. Okay. Thank you. Thank you, Neeraj. Thank you, Rajen.
Thank you, sir.